This is a normal heart, and this is cardiovascular, and it will be in 3 sections, I think, also. And I know census was only in 2. This should be in 3. This is showing the normal heart, and I would say that this guy has some atherosclerosis. If you look at that, the yellow padding around the different arteries around here. This is showing the coronary circulation, your anterior descending and your circumflex branch and your right coronary that come off, and the major vessels that you have normal. This is a transection of the heart where they've cut it in half. And even if it were not labeled, you would be able to look at the right and left atrium and know that the left was on the right here, which is the opposite of what they're labeled. But anyway, it's on the right because the muscle layer is thicker, because it has to pump to the whole body. Where on the right, that muscle layer is thinner because it only has to go as far as the lungs. And the atria are basically just collecting chambers. And so this is showing the normal chambers of the heart muscle and the valves that are in there. So, cardiovascular assessment. As the nurse, you need to get a history. And your history is always dependent upon how your patient feels at the time. But let's say you're just basically going to do an evaluation of somebody who comes in and is currently having no pain. So you can ask them anything you want. Remember, your pain scale is always 0 to 10, or 0 to 5, or 0 to 5,000, whatever you want to come up with. But as the nurse, you want your patient to have no pain. So you never start the scale with 1. So the symptoms you're going to look for are those not only pain, but the associated symptoms. Do they have any nausea, vomiting, radiation of that pain, any diaphoresis? Their patient profile, their age, sex, weight, health habits. Do they smoke? Their support system, because research has shown that if you have a support system, you do better than if you don't. Your cultural information, because that makes a big difference. I took care of a young man, he was only 42, who had had a heart attack, and he was from Greece, and he was basically off the boats because he was a mariner and had developed the heart attack when he landed in Toledo off of one of the boats. And he refused to admit to pain because culturally he wasn't allowed to. The only time we knew this man was having chest pain is when his ST segment would start to climb. We would ask him if he was having any discomfort, and his nails would be digging into the sheets, and he would say no. He did not survive because he was not able to modify and admit to having any discomfort or that he needed to limit anything because of his culture. Their emotional status. Remember, if you're really, 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 really upset and you get a paper cut, it's like the last straw, and you just can't deal with it. But if you're having a great day and you feel great and emotionally you're on top of the world and you get a paper cut, you go, not a big deal, and keep on going. Your perception of the illness makes a difference. If you see illness as a gift from God to make you better, you're not going to necessarily seek medical help. If you see illness as something that you can control, yes, you will seek medical care. So you need to think about those sort of things. You want to look at their risk factors. You have risk factors that are totally non-modifiable, things you cannot change, like your sex. Regardless if you have the sex surgery, whatever you're born with is your risk factor for heart disease. And men still have a greater risk factor until they get to about 45 or 50, when menopause starts to kick in on the ladies. Now, if you smoke and or use birth control pills, that makes a difference, ladies, and that will decrease or increase your risk for heart disease at a younger age. Your age makes a difference. The younger you are, the less likely you are to have a heart attack. Your cultural identity, which we've already mentioned, and your family history. As long as your parents or family members had their heart attack, over the age of 65, it's not a risk factor for you. If they were under the age of 65, it's a risk factor for you. You need to know their genetic makeup, because that, again, is not something you can change, but that does become a risk factor. There is a family in Ireland that contains some genes that every male in that family has had a heart attack by the age of 21. And they're doing some extensive studying with them to try and figure out what the genes are that are causing it, and if there's anything they can do to prevent it. Modifiable or treatable risk factors are things like hypertension, diabetes, hyperlipidemia, dysrhythmias, your homocysteine levels that are elevated, or your C-reactive protein levels that are elevated, are all modifiable or treatable. McCarthy sign is another. Now, McCarthy sign is where you get a diagonal earlobe crease. Now, that diagonal earlobe crease occurs because you've got cholesterol sticking in your earlobe, causing it to stick together. My dad had one when he had his heart attack. My dad was 73, his only heart attack. He was 73, never smoked. He was a farmer. He worked every day. He exercised every day. His only risk factors were that his cholesterol was 400. He had McCarthy sign, and he was about 40 pounds overweight. When he got his cholesterol under control and lost the pounds, the McCarthy sign disappeared. So I know that that is something that can go away. Preventable risk factors are smoking, obesity, sedentary lifestyle, a high-fat diet, stress, hormone replacement therapy, because you don't need to take it. Now, current research is showing that if you take unopposed hormone replacement therapy, ladies, immediately after a hysterectomy or with menopause, your risk for heart disease remains decreased. If you wait to start hormone replacement therapy, say a year or longer, then you have an increased risk for heart disease. Or if you use estrogen and progesterone together, you have an increased risk for cardiovascular disease. If you have an increased waist to hip ratio, for men it has to be over 1, for women over 0.8 in women, you have an increased risk for heart disease. And again, your homocysteine levels can be here also because they cause inflammation. And if you take your B vitamins and your green leafy vegetables, you can actually prevent that from ever occurring. So what's preventable or modifiable tends to blur a little bit. Your family history, you're looking for heart attack, stroke, hypertension, diabetes, coronary artery disease, collagen vascular disorders, anything that's going to affect the vessels, the blood vessels. You want to know their prior test results. Have they had a cath in the past? Have they had an EKG in the past? What have they done? What's their medical history? Do they have a murmur? Have they had a recent strep infection, rheumatic fever, prior surgeries or medical conditions such as a pacemaker, an ICD, which is an implantable cardioverter defibrillator, coronary artery bypass graft surgery, or ventricular assist device? What are their allergies and their recent dental work? What medications do they currently take? Are they on anticoagulants, antihypertensives, antidysrhythmics, digitalis, nitrates, diuretics, hormone replacement therapy, antiplatelets, beta blockers or calcium channel blockers, statins? What sort of herbal drugs do they take? What kind of meds are they on? You also want to know if they drink. Now, if 1 drink a day has been shown to be beneficial. Now, that's 1 serving. And 1 serving is 5 ounces of wine, or 12 ounces of beer, or 1.5 ounces of the 80 proof alcohol. So it's not the whole bottle of wine, the whole bottle of alcohol, or the case of beer. You need to do a physical exam. And on inspection, you're going to look at their posture, their color. You want to check their tongue for central cyanosis. You want to check their neck veins, jugular vein distension at the end of exhalation. with the head elevated 45 degrees. You want to check for an abdominal jugular reflex, because that'll tell that there's too much fluid in the liver. You want to check the thoracic reference points to make sure you hear S1, S2, and if you hear S3 or 4, or if there is any murmurs that you hear. Check your point of maximal impulse, which is in your midclavicular fifth intercostal space. You want to check their extremities. Yes, ladies, you should have hair on your toes. If you shave them off, you need to tell them that. Because if you've got hair on your toes, that means you've got good circulation there. If you don't, you don't have good circulation there. You want to know the skin temperature, their texture, the color, if there's any edema. You want to check for clubbing, and you check for clubbing not only by just looking, but you want to have them put their digits together. And check to see if you see a little baseball diamond between the nail and the first joint of their digits. And if they do not, if it's starting to flatten out, that means that the digits are not getting the oxygen that they need, and you may have somebody who's smoking more than they tell you they are. You want to palpate their pulses, and those are graded on a 0 to 3 plus. You want to palpate the carotid low to avoid the carotid bodies, because you don't want to put any pressure there, because that will slow the heart rate, and that's not necessarily a good thing. If you have pulsus alternans, that means every other pulse is strong and then weak. That tends to indicate severe left ventricular failure, and it's not a good sign. You want to palpate the abdominal aorta gently. Now it should be the size of the thumb. If it's larger than that, and if it's pulsating, don't push on it. Just gently identify the borders and the size, and listen to see if you hear a bruit. You want to check capillary refill time. It should take less time than it said to say capillary refill time. You want to do an Allen test to evaluate flow to the hand, and that's where you have them make a fist and occlude both the radial and the ulnar arteries. And then while they are occluding the radial artery, you release the ulnar and open the hand, and the blood supply should return to normal very quickly. If not, you cannot use that hand to do either use for bypass or to do for blood samples. You want to check their DP and dorsalis pedis and posterior tibial pulses. Keep in mind, 90% of the population have dorsalis pedis. 10% do not, but 100% have posterior tibial. You want them to check for a deep vein thrombosis. Make sure they can identify where the PMI is located. Now your PMI, your point of maximal impulse, as I said, should be fifth intercostal space, midclavicular line. You should be able to put your hand there and feel it. You should be able to see that pulsation when the patient's lying flat. If it has shifted to the mid-axillary line, you have a patient with cardiomegaly. You don't even need to do an x-ray to find that out. So it's very valuable information. You want to auscultate for their blood pressure to check for carotid or femoral bruits. Listen for heart sounds. Make sure that you don't have an S3 and an S4. This is clubbing, and again, I've talked about where you put the digits together. If you're just looking at it, you might see this. You've got your normal nail in the upper left. You've got early clubbing in the upper right, and it's worse in the lower half of this. Keep in mind this happens on the toes also. You need to do your diagnostic tests, your electrolytes, your potassium. If you have too much potassium, you're going to have tall peaked T waves, which you already know because you already had renal last semester, and renal will if you're in renal failure, you'll have tall peaked T waves. You'll have a widened QRS, prolonged PR, and it can cause ventricular standstill or fibrillation. If you have low potassium, you're going to have lots of PVCs, maybe have runs of ventricular tachycardia or fibrillation, may develop a U wave. If you have too much calcium, you'll have all types of AV blocks could occur, bradycardia, or an increase in digeffect. Hypocalcemia bradycardia to ventricular tachycardia and asystole. Your QT will be prolonged, and that puts you at risk for torsade de pointe, which we'll talk about later on, but that's basically a different type of VTAC VFib. It's not healthy. Magnesium is really important for the heart. Now, hypermagnesemia is very rare, but hypomagnesemia occurs with hypertension, vasospasm. It prolongs your PR and your QT. It can cause a U wave, a wide QRS, SVT, supraventricular tachycardia, and torsade de pointe. So magnesium has to be fixed. In fact, magnesium has to be fixed before low potassium has to be fixed, because otherwise you cannot correct that low potassium. You need to do cardiac enzymes. Now, your cardiac enzymes are your CK and your CKMB, your LDH, which isn't done very often any longer, but it's fractions. And your CK will elevate in 4 to 8 hours and peak in 24. It returns to normal in 3 to 4 days. Your isoenzymes are either MB, or BB. BB is for brain. MB is myobands, or your heart, and MM is muscle. So, if you decided to run down the stairs from second floor to first floor, missed the second step, and proceeded to go all the way down on your bum to the end of the steps, you'll have 100% MM if you do blood work. If, on the other hand, you hit one step with your rear and the other one with your head, you'll have MM and BB. On the other hand, if you decide to hit every third step with your chest, you probably will have a lot of MB also, because that's where your heart is located. Now, your LDH, lactic dehydrogenase, will elevate within 24 hours, and it peaks in 3 to 6 days. So it's a nice thing to do if you have somebody who came in and said, you know, I haven't been feeling right for the last week. They can do an LDH, and if it will still be elevated, and will tell you whether or not they've had a heart attack. It tends to return to normal in 10 to 12 days. Now, you have to look at the fractions in order to determine whether or not it's liver or whether or not it's heart muscle. That's the problem. And there are 5 fractions with your LDH, and they're numbered 1 through 5. If you were to look at the fractions, they're like looking at the back of your hand, with LDH1 being the thumb, which is very low, and LDH5 being not quite so high as the others. That's the normal pattern. When you have what's called an LDH flip, you'll have 1 greater than 2. And if you have congestive heart failure, your level 5 will be quite elevated. So 1 and 5 are the ones that you really look at. 5 will elevate with liver congestion, CHF, and cirrhosis. Then you look at your myoglobin and your troponin, and your myoglobin will tell you if you have a physiologic cause for pain. It will return to normal within 24 hours. Troponin I and troponin T are cardiospecific and are the ones that are done most often nowadays, because they're a little bit cheaper than the other tests. It will peak in 24 hours, and because they last 9 days, they rarely do the LDH any longer. But you can still see that being done. And you can get the results for troponin I and T within an hour, so that's good. Hematologic studies, you need to do a red blood cell count to make sure you have enough oxygen carrying capacity of the blood to saturate that SaO2. So you have to do an H&H. You do your clotting studies, PT, PTT, and INR, and coag profile, because if you have to give a thrombolytic, you need to know baseline to start with. You need to do your lipid studies. You want your cholesterol to be below at least 200. Now they're talking about having it below 180. VLDL is the very worst. You want less than 25% of the total. LDL should be below 130. And your HDL is considered protective because it returns cholesterol to the liver to form the hormones that we need. We really do need a certain amount of cholesterol, not a lot. You want your HDL to be at least 45 or better, 45 milligrams per deciliter. Now your triglycerides are precursors for cholesterol, so you want that less than 150. And your VLDL formula is to take your triglycerides and divide it by 5, and that'll give you your VLDL. Now, your optimum lipid profile is drawn in 12 to 14 hours, drawn with a 12 to 14 hour fast, and not taking any aspirin, steroids, which includes your estrogen and your oral contraceptives, within that time frame, because that could cause inaccurate results. If you're not fasting, it can give a false triglyceride level. And the thing about your lipid studies, if you've had a heart attack, you have to do them within 48 hours because they'll return to normal for 6 months after a heart attack. There's a table on page 944 to 946 that you need to look at for diagnostic procedures. BUN and C-reactive protein. Now, BUN with a normal creatinine is for hydration. So if you've got a normal creatinine and an elevated BUN, you're dehydrated. If you have a normal creatinine and a low BUN, you are overhydrated. I don't know what I just said, so I'm going to say it again and make sure I know what I'm saying. If you have an elevated BUN and a normal creatinine, you're dehydrated. If you have a low BUN and a normal creatinine, you're overhydrated. So BUN is for hydration status. It's a blood urea nitrogen. A BUN is something you eat or look at. C-reactive protein is an inflammatory marker. It predicts the risk of an MI or stroke better than your LDL levels. It's not cardio-specific, though, because it's just an inflammatory marker. Your thyroid studies look at your basal metabolic rate. Your BNP your ANP is your atrial natriuretic factor, and your BNP is your brain natriuretic factor, or peptide, for both of these. And these are both produced by the body in response to overhydration. So ANP is found in the atria, and BNP they thought was found in the brain, but it's also found in the atria, or in the ventricles of the heart, and it's due to an increase in fluid volume. So what it causes the body to do is to vasodilate your arteries and excrete sodium, and it makes these changes in just a few minutes. So if your BNP is elevated or your ANP is elevated, your patient is severely overhydrated. You need to look at your chest x-ray, which shows your heart size, congestion, and rules out a pulmonary cause of chest pain. Now remember, it takes 24 to 48 hours to show congestion on a chest x-ray after you find it. And usually by the time you hear crackles, your patient's gained 10 pounds of water weight. Hemodynamic monitoring is looking mainly at your cardiac output and to make sure that your patient has enough volume on board. And we'll talk about that a little bit further going on. Electrocardiogram could be either a 12 lead or an 18 lead. Now an 18 lead also looks at the posterior wall in the right ventricle, where a 12 lead looks mainly at the left ventricle. So the 18 is your posterior wall in your right ventricle. Or you could do a right-sided EKG where you put the leads all on the right side just to look at that right heart. You can assess for a Q wave or a non-Q wave MI. And you can do a Holter monitor, which is where somebody wears a recording device that records their EKG continuously for 24 to 48 hours. I had a patient who was having chest pain, and so we put him on a Holter monitor, and you have to keep a diary. And we told him he had to be faithful about writing everything down. And when he had his chest pain, and he brought it back in, and I'm reading the diary, and he told how he had sex with his wife in the morning and breakfast and went to work and everything was fine, and he took a break and had sex with his secretary and had chest pain. And then he went back to work and went to lunch and had sex with his secretary and had chest pain. And then he went back to work and then took an afternoon break and had sex with somebody else and had chest pain. And then he went home and had dinner with his wife, and that evening had some more sex with her and didn't have any pain. I think it kind of pointed out that it has to be usual person, usual place if you don't want to have chest pain. Did kind of make me giggle a little bit. You can do stress testing, either a treadmill, where they actually get on a treadmill, which increases in speed and angle over time, or you can do a non-stress, where you give the patient a drug, and the drug will stress the heart, like a dipyramidol or Persantin. You can do an echocardiogram or a phonocardiogram to look at the heart chambers and the pieces that are there, and a Doppler echo to see how things are going. This is what a normal 12 lead looks like. And as you can see, if you look at it, the R waves change in height as you go through. The direction of the, or the height, length of the S wave changes. The position of the T wave will be different. And it's the changes from the norm. It's what they look at to identify the abnormalities. Now, this is someone saying a stress test, and it says, it's not looking too good. His pulse is up to 202 just from getting out of the chair and stepping onto the treadmill. And that's not a good sign. Now, GXT is a graded exercise test. This uses a treadmill, such as you see here, or a bicycle. It's used to diagnose coronary artery disease. You can do a non-stress test using medications such as dipyramidol or Persantin or dobutamine, because those agents will increase the heart rate and you'll get a similar effect. You do that for somebody who had severe arthritis, had trouble moving. Maybe he should have had it done. I'm not sure. Some other diagnostic procedures are a TEE, which is a transesophageal echocardiogram, or an MRI, which is to a magnetic resonance imaging, which would look at the whole heart. You have nuclear medicine studies where you could do a thallium scan, which is a cold spot imaging, where the dye goes to the healthy tissue and the diseased tissue shows up as a blank spot on the area. The thallium scan can be done at the bedside. A MUGA scan is a multi-gated scan where it basically looks at the heart as a whole and then takes pieces away as it goes through, so you can check your ejection fraction or how well that contractility is going with that one. Cardiac catheterization is done to diagnose coronary artery disease. Electrophysiology studies are done for arrhythmia diagnosis. I had a lady who had lethal arrhythmia. In one 16-hour time frame, she was counter-shocked 62 times and also received a precordial thump about 14 times to try and convert her, because she kept going into VTAC and VFib. They sent her for EPS studies at MUO, because they did not do those at the facility I was at. Except it's not MUO any longer, it's now UTMC, Medical College. And anytime you do electrophysiology studies, you have to take them off of all their medications, and then they try and initiate that dysrhythmia so that they can then either burn or freeze that area out. And she's doing quite well now, but I wouldn't want to work in that area. That'd be very nerve-wracking. A tilt table study is done to assess for syncope, to try and figure out what the problem is there. Arteriogram, again, is for cardiac cath, or to look at blood vessels elsewhere in the body. And you have your Doppler studies that also look at flow rates. Think about this. We have Dad. We got high and lows. Ditto says to Dad, "Dad, did you? If you keep doing that, your father's going to have a coronary. Like when you make him a king." It's really important that you make rounds with your physicians, because he often uses words to the patient that the patient cannot understand. I was doing cardiac rehab, and I had a patient who had had a heart attack, and he was a young man. And I was waiting for the doctor to tell him that he'd had a heart attack so I could tell him what he could do to make himself better. That it didn't mean he had to sit in a wheelchair for the rest of his life. And the doctor snuck in and out without my seeing him. So I went in to see the patient, and the patient said, "Oh, I feel so much better." I said, "You do?" Because let's face it, that's not what I expected. And he said, oh yeah, I thought I'd had a heart attack. And I said, yes. Well, the doctor said that I had something called a myocardial infarction. I said, infarction? He said, yes. I said, I have good news and bad news. Bad news is, that's a heart attack. Good news is, doesn't mean you have to retire from life. If you make rounds with your docs, and they say words like that, because let's face it, they don't like to give bad news either, you can turn to the patient and say, do you know what that means? Because let's face it, they get paid a whole lot more than we do. They should be the ones giving the bad news. This is a cardiac cath showing a blockage, and there's that lovely little arrow that shows you where it's located. Unfortunately, they don't do that all the time, but that is a nice thing if it will. There are different types of hemodynamic monitoring. You can have an arterial line to assess continuous arterial blood pressure in order to obtain blood samples. You've got a CVP, which is central venous pressure, which measures the pressure in the superior vena cava or the right atrium and addresses fluid status. You've got your telemetry monitoring, which is one lead or maybe two leads of a 12-lead ECG. And you've got your thermodilution pulmonary artery catheter, which again measures cardiac output and hydration, and we'll talk more about all of these. Arterial line monitoring is done for continuous blood pressure monitoring to obtain their mean arterial pressure in order to obtain blood gases, particularly for when somebody's on a ventilator, and you're doing this very frequently. The waveforms on an arterial line will show your systolic and diastolic pressure, or if they're dampened, it means that the tip is against the arterial wall or there is a clot at the tip. So if you look at this pattern, you'll see on the one on top the normal waveform, where you have systolic is the tallest and diastolic is the lowest. And that's your normal waveform, and you'll have that on graph paper, and you'll be able to determine a blood pressure with that. The waveform below is showing one that is dampened or has a problem. Now, you can get really involved looking at your arterial waveform, and they get very determined as to what's going on. You've got a systolic upstroke, a systolic peak pressure is number 2. You've got number 3 is your systolic decline, 4 is the dichrotic notch, 5 is your diastolic runoff, and 6 is your end diastolic pressure. Basically, we're concerned about number 1 and number 6. If you have problems with your arterial line, it could be that you have a clot at the tip, or it's come disconnected and your patient's bleeding all over the place. Not a good thing. Or an air embolism could occur. When you have loss of waveform, it means that you probably have a clot at the tip, or the catheter is kinked, or there's a problem with the transducer. Or if the waveform does not correspond with the digital readings, there's a problem and you have to recalibrate your equipment. A CVP's purpose is to identify filling pressures in that right heart and measure them, to identify hydration status, and to assess right ventricular end diastolic pressure, because that will give you volume that's there. It's not a good measure for left ventricular function. You can do a CVP with your patient lying flat up to about 60 degrees and still get an accurate reading. So if they cannot lay totally flat, you can elevate the head of the bed a little bit. Your normal CVP is 2 to 5 millimeters of mercury. It uses a transducer and a monitor to do that. If you're using water, you use just a manometer, and the normal then is 3 to 8. And you need to identify the phlebostatic axis, and this is showing you your phlebostatic axis on the bottom. It's your mid-axillary line, and that should be your 0 point. And you've got your fluid up here that comes down to a stopcock, and then you'll turn it so that it fills the manometer, and then you'll turn that off and have the fluid go into the heart. And then it'll get down to a 0 point, and when this stops coming down, that's what your CVP will be looked at. And the CVP waveform has 3 peaks and 2 descendants. You're looking again at systole and diastole, and it shows you at the top what those changes are. And again, you're looking more at an average, or at where it's at the highest, that a peak that you're looking at between A and C is where you'll identify your CVP. We really, at least I never bothered to identify all these pieces, but they do this for research. This will end part 1, and we'll start with part 2, the PA catheter, in just a moment.